welcome to the March 2023 Continuing Education lecture. This month, as we do with many of the months that we've done previously, is going to be a total of 3 topics, starting out with capnography, managing patients one breath at a time, the CE hour distribution for this month, and all 3 of these really should probably fall under the NCCP content because they are required hours as part of the 30 hours of core content that everyone is expected to get. So if you have been on with us from the very beginning, believe it or not, we're at a 2-year period. So we started in March of 2021. Now being March of 2023, we're kind of starting over as far as those core hours. If you have not been with us from the very beginning, it's still important for you to make sure that this is documented appropriately in that core content area, because the local and individual content are essentially electives, and these hours would count for those electives if you in fact went over the required amount for each of these sections. So for instance, with oxygenation, the true requirement is a half an hour in that content area. But if you've already got a half hour of oxygenation and met the requirement after today's lecture, then essentially you would be a half hour over, in which case you could use those hours for the individual or local content as well. So the 3 different breakdowns for today: the NCCP content, a half hour of oxygenation. The second portion is 1 hour in ventilation, again, following the NCCP content. And then the third hour is going to be 1 hour of capnography, not necessarily in that order. We're going to start off with capnography first, as I had mentioned to you. Just as an example, though, when we are looking at the hours breakdown from the National Registry, there's actually 2 hours of ventilation that is required. So if you guys will document 1 hour of ventilation today, moving forward, we'll make sure that you have another hour of ventilation in the upcoming months. So the objectives for the capnography portion here, we're going to look at the difference between ventilation and perfusion. We'll talk about capnography and what that is, the capnograph versus capnometry, and then look at a couple different ways that we have been able to do that previously, and probably should still have some access to just from a medical legal aspect. We'll talk about that as we get into it. We'll also examine the ways that are the aspects of the respiratory cycle, talk about different ways to collect the end-tidal CO2 information. And that's what I was just referencing with looking at some of the historical approaches and how we can best obtain information if we do in fact have a patient that has an endotracheal tube through their glottic opening, because that really does become a medical legal thing. If we have a patient in that situation where we have taken their airway or intubated them, we need to make sure that we have good objective feedback to ensure that the tube is still through the glottis and we can ensure that the patient is being oxygenated and ventilated appropriately. So, and that's why really we get into capnography and it being a Class 1 recommendation from the American Heart Association, because we know that patients that are just simply on pulse oximetry don't typically desaturate very quickly. There's a slide in here and we'll just talk about that very quickly. We're going to look at physiology as it relates to respiratory rate and end-tidal CO2. We'll evaluate end-tidal CO2 waveform, the 4 different phases. I think that most people at this point have had capnography before and feel pretty comfortable in looking at the waveform. But in the event that you have somebody that's new or somebody that's not been through the information before, we'll take a few minutes to look at the different waveforms. That it's not all that difficult to understand and interpret once you know what you're looking at. We'll also discuss the use of capnography in intubated and non-intubated patients. So, you know, we always look at this as a Class 1 recommendation and a medical legal aspect for your intubated patients. But what about those individuals in a non-intubated situation? So patients that are suffering from an exacerbation of COPD, maybe it's a pulmonary embolus. So other things that we may be able to look for on capnography, even in a non-intubated patient. And then finally, we're going to discuss treatment options based on end-tidal CO2 waveform. So taking the information that we find from the waveform and applying knowledge and best practices for adapting and changing the way that we're going to approach patient management so that hopefully we can optimize their care. So why is this important? Well, according to the Cleveland Clinic back in 2019, they had come out with a statement that vital signs are used to measure the body's basic functions. There are 4 main vital signs that we generally talk about: the body temperature, blood pressure, the pulse or heart rate, and then the respiratory rate or the breathing rate. But capnography has long been considered the ventilation vital sign. So why do we not use that more frequently as pre-hospital providers? So we obviously want to know the respiratory rate and what else is going on with the 4 main vital sign groups, but we should also understand what the patient's ventilatory status is. So there's a lot more to be said than the patient has a respiratory rate of 12 or 16. We really need to know how well they're actually ventilating. And it kind of goes back to some other topics that we've talked about in the past. If you respond, we've all had these situations where we encounter a patient's family member and, the patient really doesn't want to go to the hospital, but the family member wants you to get a blood pressure. Well, what does that blood pressure mean? And if you ask the family members, what exactly are you looking for with the blood pressure? My guess is that they really probably don't know exactly what they're even asking for. They just feel better because you can give them a number that sounds reasonable, and then they think that everything is going to be okay. But as we've talked about in cardiology and some of the other lectures, it really isn't even blood pressure that we're worrying about or thinking about in a lot of instances when we're talking about a patient, especially in a critical care concept. It's really more guided based off mean arterial pressure. And if you recall back from a few months ago, when we had talked about this, a mean arterial pressure of less than 65 is really where we start to be a little bit more concerned, because we know that they're not having end organ perfusion. Yeah, they might have a blood pressure of 100 over 80, but when you do the math and break that down and figure out what your mean arterial pressure is, that may not be enough to make sure that they're actually getting oxygenated blood to their heart, their brain, and their kidneys, which are the vital organs that need them at all times. So there's a lot of information that we can get from capnography, and it kind of relates to that as mean arterial pressure. Yeah, we know that they're breathing 14 or 16 times a minute, and based off of the Brady Care book in either EMT or paramedic school, that falls within the normal range. But how well is the patient breathing? What is their true ventilatory status? And that's really what we should be asking ourselves. So ventilation and oxygenation. Ventilation, simply put, is the movement of air. And I always would teach this in entry-level paramedic education, the difference between ventilation and oxygenation, or ventilation and perfusion. Ventilation is the mechanical process of movement. So simply put, the movement of air. When you are encountering a patient that is apneic or a cardiac arrest victim, and you get a bag valve device, you are ventilating the patient because you're causing their chest wall to actually move. So that is totally different than what the concept of perfusion is, and we'll look at that here in just a moment. So with ventilation, you have chemoreceptors that are located in the medulla oblongata, which is in the base of the brain, and these sense elevated CO2 levels or low pH. So that is actually the stimulus to breathe under normal conditions. When your carbon dioxide level goes up, your body recognizes that as you have an elevated CO2. We know that CO2 and oxygen are always an inverse relationship, meaning if one is up, the other is down. So as our end-tidal CO2 or our CO2 ends up elevating, then that should be the stimulus for each and every one of us that doesn't have a hypoxic drive to take a breath. I actually had a professor in college at one point that said he really never gets offended if you have somebody in class that takes a breath, because it is a physiological function. When you take, I'm sorry, I said a breath, I meant a yawn. When you yawn, it is actually your body's ability or way of trying to normalize your CO2 and oxygen level, and that is why individuals will yawn. It's to try to get that back into a more homeostatic state. So low pH, we don't really talk about from the pre-hospital world for the most part. We can look at some arterial blood gases and reference those to pH and what that means. But under normal conditions, we don't just simply measure pH in the field. So If your CO2 is going up, that means your oxygen is low. Your brain says, hey, I need to take a breath. That is the stimulus for each one of us to breathe. The triggers that maybe either go against or go more towards hypercarbic drive. This is going to trigger ventilation. So hypercarbia is an elevation in CO2 as well. And that's a little bit of a problem. And when we get into some of the other ways that we can look at capnography and end-tidal CO2, I'll talk about how we can actually create that for our patients, primarily our pediatric patients, and that would not be a good thing. Hypercarbia can cause a lot of downstream effects that we really don't want. So if we're excessively ventilating the patient, but we're not doing that effectively, we can in fact actually end up causing a little bit of hypercarbia. And then finally, the hypoxic drive is your backup plan. Remember that with hypoxic drive, I don't want to go real in depth on this. We'll talk about that more when we get into some of the respiratory type patterns and issues with that, such as your COPD patients. But remember, with hypoxic drive, what ends up happening is those individuals are CO2 retainers. So they have chronically elevated levels of CO2. And finally, the brain just says, hey, I can't keep up with this pace. You are always telling me to take a breath because you have high levels of CO2, and under normal conditions, that would be the stimulus to breathe. Well, because your CO2 retainers never really have the ability to off some of that end-tidal CO2, the body basically has to go to a backup plan. So the backup plan with your hypoxic drive patients, or those that have COPD, is essentially they end up having a stimulus to breathe based on low oxygen levels, which is why if you went through class, 20 years ago or so, it was kind of controversial on whether or not we offered oxygen, or especially high flow oxygen, to those individuals. That has since been proven many times. And again, from a legal aspect, never withhold oxygen to a patient. Make sure that if they are hypoxic, or they're telling you they're having difficulty breathing, or you have some objective finding with either CO2 management or pulse oximetry that is telling you that the patient needs oxygen, please make sure that you provide that to them. On that same topic, though, if you are providing oxygen to that patient and their stimulus to breathe is low oxygen levels, just be aware that we can, in fact, knock out some of their respiratory effort, in which fact you're going to have to go to bag valve assisting, potentially the placement of an I-gel or a King, depending on what your agency is using, up to and including intubation if you need to do that. So with the diaphragm and the intercostals, these create pressure differences, which changes what the essential pressures are in intrathoracic versus an atmospheric pressure. And we know through the law of diffusion that a gas wants to go from an area of higher concentration to an area of lower concentration. So if we have 20.9% oxygen, or 21% is what most people will reference, in atmospheric pressure, and the intrathoracic equivalent to that is lower, then the oxygen is going to want to rush into the intrathoracic cavity, and that is how we end up taking a breath. So what happens here is, you guys can probably remember back to your initial training, the diaphragm contracts and moves down, and that creates a bigger area inside of your intrathoracic cavity. If we have an increase in our area, we're going to have a reduction in pressure. And when we have that reduction in pressure, gas now is forced in. Eventually, though, that diaphragm is going to relax. When the diaphragm relaxes, the diaphragm starts to move back up. The pressure in the intrathoracic cavity now starts to increase. The pressure on the inside is greater than that of the pressure on the outside. So the reverse is true. Diffusion, higher pressure on the inside. It wants to go from an area of higher concentration to an area of lower concentration. And that is how we exhale. Perfusion, totally different concept. And if you guys remember back to paramedic school, or back when you were in anatomy and physiology in high school or college, you may have talked about something named the Fick principle, and that's what we're essentially talking about here. So simply put, blood's in your body, it goes round and around, and it kind of mixes with the oxygen that you're breathing in. So hopefully we're getting oxygenated blood to go round and around. You have red blood cells, which have hemoglobin. Remember that hemoglobin is an iron binding compound, and it allows for 4 different bindings. There are 4 different areas on a hemoglobin that have the ability to allow something to attach to it. When I say something, again, you've heard this before, it might be oxygen, it may be cyanide, it may be carbon monoxide. So there are different things that do have the ability to attach to the hemoglobin, and we hopefully want to make that oxygen. So they have to have adequate oxygen. The red blood cells must be functioning normally, therefore no cyanide or carbon monoxide, as we just mentioned. And then they have to have an adequate blood pressure. If you don't have adequate blood pressure, obviously you're not ejecting from that left ventricle. You don't have good cardiac output, and therefore you're not going to have good perfusion. So why does all this matter? Well, it's because there has to be a balance. And when we talk about that, what I want you guys to kind of think about here is, what if they're ventilating, but they're not perfusing? So we're moving their chest wall, the process of mechanical, but they're not actually perfusing. They're not getting oxygenated blood to the tissue. What may be a reason for that? And the answer is pulmonary embolus. So if we have some sort of a clot, a thrombus that breaks off and then lodges in the pulmonary artery, obviously we're not going to be able to get blood flow past that occlusion or that blockage or the pulmonary embolus. And if you remember, the pulmonary artery is before the pulmonary network. It's before the lungs. So the right ventricle ends up feeding directly into the pulmonary artery. We put a clot there, and now things start to back up, and the patient will in fact potentially have signs of right-sided heart failure because things are starting to back up into the right side. They're going to have difficulty breathing, but a lot of times when you listen to their lung sounds are going to sound normal. You're not going to hear adventitious lung sounds, and that's because it's really not a pulmonary issue. The problem with a pulmonary embolus is before the lungs, therefore the lungs are going to sound pretty clear. It's going to be a sudden onset of difficulty breathing, but again, their lung sounds are going to be clear because the issue is not in the lung itself. What if they're not ventilating, but they're perfusing well? So think about an airway obstruction. It could be an overdose type situation, especially with our narcotics or opioid type medications that cause them to have respiratory depression. And then not ventilating and not perfusing at all, then we're thinking about a situation like a patient that may be in cardiac arrest. So what are we actually looking at? We always say capnography, and we're throwing those things around pretty loosely, but what is it? So if we're looking at a device like the one diagrammed on the left with capnometry, that is simply just looking at the numbers. And then the one on the right is a capnogram, and that is actually the digital waveform printout, but maybe doesn't have numbers associated with it. And that's just trying to give you an example of the waveform itself. That is a capnogram. So if we are talking about capnography, what we are actually referring to or looking at is a situation where we have both the waveform or capnogram, and we also have a digital printout or the numbers like the one on the left. So that is actually what waveform capnography is. And I think that most of us are probably using in today's world. So when you combine both capnometry with numbers and capnogram, the waveform, it gives you a total of waveform capnography. And this really is the true class 1 indication or recommendation from the American Heart Association, primarily if you have a patient with a secured airway, we've intubated that individual, so on and so forth, and we really need to be using waveform capnography. It kind of still amazes me that pre-hospital care is so far ahead of the curve in a lot of this, but in the hospital setting, they haven't really caught up to that point. I do think that they're getting better about using capnography, and certainly the respiratory therapist and probably most of your emergency medicine physicians are aware of this. But quite simply, the registered nurses or ER nurses in a lot of these situations are just not educated on it, to be totally honest with you. And it's not that they don't have the ability, it's just they have not had the opportunity to have the education in one of their breakout sessions or whatever. So they're not real familiar with the capnography, but I do think that it is getting better. To kind of go along with that, there is hospital policy, and it's been policy for many years here in our region, that if they're doing any type of conscious sedation procedure, so they're doing an orthopedic procedure and they have to put somebody not completely asleep, but through conscious sedation, they actually have to be monitoring capnography. And I know from years ago when I worked in the ED, I would ask the question, what are you actually looking for? And the nurses would go, we don't really know. It's just a policy that we have to do it, but we're not sure exactly how to read the waveform itself. So a couple things here on obviously the picture of the monitor here. The top, you have your lead 2. As we kind of go down here, you have your oxygen saturation and your pleth, and then the next one down, which is what we're looking at here, is your CO2. And you can see that the CO2, there are some dotted lines here with a number of 25 and then 50. Their CO2 in this situation is 5. And this could be directly related to perfusion. So if you look at their blood pressure, and this individual has a systolic pressure of 97, a diastolic of 56, that ends up giving you this equated mean arterial pressure, or MAP, which is 66. And if you remember before, I said anything less than about 65, we really start to worry. Under normal conditions, this mean arterial pressure should be somewhere around 90. That's what you probably would typically find in a normal, healthy adult. So if you're seeing mean arterial pressures of 66, somewhere in that area, then they're probably not perfusing very well, which is why we are in fact getting the capnography number of 5 based on our digital printout here. So we're really all full of hot air, and I think some of us probably more so than others. But tidal volume is the amount of gas that is moved in one breath, and it typically ends up balancing out around 500 cc's in an adult patient. This equates to about 5 to 7 cc's per kilo of body weight. And this number is important for any of you all that have a transport ventilator or the ability to put your patient on a vent. If you can dial in how much tidal volume the patient should get, it should really be based on somewhere in that 5 to 7 cc's per kilo body weight. So if you had a patient that weighed 100 kilos, for instance, then you would want to set your tidal volume to 500 based on that 5 per kilo. If the patient still does not seem like they're coming around, they're not ventilating, and this is a whole different topic as far as ventilator strategy, you can increase the tidal volume that the patient is getting. You can increase your respiratory rate, you can increase your FiO2, or the amount of oxygen that you are actually delivering to your patient. And again, that's a whole different topic, but I want you to be familiar with that 5 to 7 cc's per kilo, because I do know that some of you have a transport ventilator with the ability to change how much tidal volume that you're delivering, and you don't want to cause barotrauma by giving too much tidal volume. So the way that we prevent that is we start at 5, and then we kind of titrate to the effect beyond that portion. Minute ventilation is the amount of gas that is moved in 1 minute, and this is determined by multiplying the tidal volume and the respiratory rate. So if you're in class, you're getting ready to take national registry or maybe a respiratory exam, you should probably know both of these from the national registry's perspective. So tidal volume, about 500 cc's in an adult, and then minute ventilation is just how much gas we're moving. So you have to take your tidal volume, which is typically 500, and then you multiply that by however many times a minute they are breathing. So 500 times 12 or 500 times 15, whatever that situation would be. And then obviously you could come up with your answer pretty easily with that knowledge. So where are the gases located? When we talk about looking at capnography and doing waveform studies, we need to know where the gases are coming from. And this is probably one of the most important concepts in this entire presentation of capnography alone. So we have alveolar ventilation, and that's the volume of gas that actually gets down and reaches the alveoli. It's down there, it's doing the work that needs to be done, Gas is offloading, gas is onloading, oxygen is getting into the tissue, CO2 is getting from the tissue back into the alveoli so that we can breathe that off through exhalation. So about 350 milliliters of gas actually gets down to the functional part to do the work. And remember, tidal volume, we have 500. So if 350 is going down and doing work, that means that we have another 150 that is not necessarily getting down for alveolar ventilation. So where is that 150 located? And the answer is it's dead space. It's called anatomical dead space. And that is the portion of gas that does not make its way all the way down into the alveoli. So where is most of that being housed? It's in the trachea or in the upper airway. So if you can see the red lines here, this is where your dead space or your anatomical dead space is located. So that is full of gas all the way down here into the right mainstem bronchus, but the gas has not made its way all the way back down into the alveoli. And that becomes very, very important to understand when we start looking at waveforms and why the waveforms are the way that they are. So remember, your trachea here is nothing more than just a conduit. There is no gas exchange whatsoever that takes place there. In order for gas exchange to take place, it has to be down here in the alveoli. The alveoli, just again to refresh your memory, the alveoli is the pulmonary capillary membrane is where those are located, is down in the alveoli, and the pulmonary capillary membrane is 1 cell thick. That becomes very, very important when we're talking about the diffusion of gas. It is easier for gas to diffuse across a membrane that is 1 cell versus trying to diffuse across a membrane that is very thick, like your trachea would be. And that is why we don't have any type of gas exchange here. It's simply just a pipe or a conduit to get the gas down to the area where it is more functional. So why does all this matter? Well, when we look at the respiratory cycle, if we can kind of understand and think about how the respiratory cycle generally works. So we have oxygen, obviously, and atmospheric pressure. The diaphragm contracts and moves down. We end up having a reduction in pressure in the intrathoracic cavity. When that happens, it is our stimulus to breathe because of diffusion. So oxygen ends up moving in. It goes down through the trachea, down through the right and left mainstem bronchus, into the lungs, basically. Eventually, hopefully, it makes its way down to the pulmonary capillary membrane, where we have the alveoli. That is where the functional portion is working. And then that oxygen diffuses into the blood directly. So we're now in the blood. We know that the oxygenated blood is going to make its way to the muscles and the organs, and then eventually down into the cells. When the oxygenated blood makes its way down into the cells, it is actually going to mix here with glucose. We have oxygen and glucose, and that is how we end up with aerobic metabolism. Remember our adenosine triphosphate, and you have your 32 ATP or 36 ATP. So that is where all of this is happening. And again, that's not what this topic is about, but just understand oxygenated blood and glucose are down in the cells, and it yields energy. Once we have energy, we now have to have a byproduct of the energy. And that is where your CO2 comes in. CO2 is a byproduct of metabolism. Energy is metabolism. So once we have energy and we have metabolism, we are going to now yield a byproduct of that we need to get rid of. And that is where CO2 comes in. So now we have CO2 in the blood. It has diffused from those cells back into the bloodstream because it was in an area of higher concentration than lower concentration. The CO2 comes back up into the lungs, and we end up exhaling that in a breath-to-breath format. So a common myth is that oxygenation is the complete respiratory cycle, and it is not. That's not the case at all. The respiratory cycle is comprised of oxygenation, metabolism, and ventilation. And if you understand that, then you're probably on the right path for being able to interpret what we're going to look at here in just a few minutes. So CO2, byproduct of metabolism, also known as the gas of life. Very, very important to understand that. So what about the semi-quantitative capnometry? So I think that most of us are pretty squared away or dialed in now with intubating a patient, putting them on capnography, looking at the waveform and saying, yes, my tube is in. And just to kind of cut to the chase, if you have a tube through the glottis in an apneic patient, you have got them intubated, you put capnography, waveform capnography on it, and there's any variation of a square waveform, then your tube is through the glottic opening, because we know that the esophageal intubation, if we had an esophageal intubation or the esophagus, it is not going to produce end-tidal waveform capnography. So if you do have a waveform, then we know that our endotracheal tube is through the glottis. But what about if that is not working? And I know that we've had situations in the departments that I've worked at that, it just didn't work. They plugged it in. They didn't get a good reading. You have to have a backup plan. And this is one of the backup plans and what probably most of you all still carry in your units in the event that you need a backup plan. So this is something called semi-quantitative capnometry. And most of you would probably refer to this as an easy cap. That's how it was kind of identified, many years ago before we truly had waveform capnography. So the way that this works, it actually relies on a change to pH. So for a long time, and probably the easiest way to explain it is I would always just say that this is a piece of litmus paper that is in here. Hydrogen ions are very acidic. So when you have hydrogen ions, which are exhaled, and that acid hits that litmus paper, it ends up changing the color of the paper. And that is kind of true. It's not necessarily a piece of litmus paper. Essentially what happens here is this is a paper that is impregnated with a chemical that will react when an acid hits it. So same concept, but it's not necessarily a piece of litmus paper. So this results when you have CO2 and water forming H2CO3, which is carbonic acid. And when that happens, and you have carbonic acid that is actually hitting this paper, the way that we end up getting rid of carbonic acid is you break that back down. So if we combine CO2 and water, now we have H2CO3, which is carbonic acid. The way that you get rid of carbonic acid is you break it back down into water and CO2. So how do we get rid of our water? We urinate it off. How do we get rid of our CO2? We ventilate it off. And that's basically what we're looking at when we are measuring waveform capnography. So once you have placed this on, then the provider should note a change to the paper color. And most of us would say, yep, it goes from, yellow to purple, or purple to yellow, I should say, purple to yellow. And you may have heard or remember something from when you were in class about Big Bird is good and Barney is bad, right? So there's all these different ways that students come up with, and that's fine, whatever makes it stick for you. Here's my question though. What does the number actually mean? So if we put this on the end of an endotracheal tube in a patient that we are ventilating, and that goes from yellow to purple, what does that actually mean? I want you guys to kind of think about this, not necessarily, if somebody wants to answer, it's fine. I'm not necessarily looking for an answer, but I want you to think about this because probably what you have documented previously is that you have a positive color change on your colorimetric device, which is what this is called, or on your easy cap. But in the event that you have that color change, what does it actually mean? And I want you to think for just a second here. In the meantime, I'm going to make sure that everybody that kind of joined us right at the last minute has the ability to talk. Okay, so if you just think internally or in your training or in the people that are with you, how many of you have used this device? If you'll just kind of, nod or throw your hand up if you've used this device at some point in time in your career. And if I'm a vetting person, it's probably documented in the report where you used it that you had a positive color change, but none of us have really ever been taught or taken the time to figure out what that actually means and what the numbers are. So let's take a look at that. So if we're looking at the colorimetric device or the EasyCap, if you notice there's an A, a B, and a C on this colorimetric device. And with the A, remember I said before, Big Bird, which is yellow, is good. Barney, which is purple, is bad. So if we are looking at the A category, what you're actually trying to do is match the paper color to the border of your colorimetric device. What color is the paper in relation to this key out here on the edge or the perimeter? So if your paper color is over here in this A, it's dark purple, and it matches up to this purple, that gives you a 0.03 to a less than 0.5% of CO2. That equates, and this is done through a mathematical calculation, that equates to what we are looking at, which is a pressure of millimeters of mercury to less than 4. And if you remember back to capnography, or whenever you taught or were given this information initially, a normal end-tidal CO2 from the day you're born till the day you die should be between 35 and 45. So we know just very quickly looking at this information, less than 4 isn't even close to what it should be. All right, so then we look at B. So again, we're looking at the paper, we're comparing it down here to the area of B, this brownish color. That gives you 0.5 to less than 2%. But what we're really looking at here is the millimeters of mercury, and it's 4 to 15. Again, still not a great finding. And then we go to C, and that's 2 to 5%, and that's giving you an end-tidal CO2 based on the hydrogen ions that are hitting this paper of anywhere from 15 to 38%. So even if we're over here in the C, the highest that this colorimetric device is going to be able to give you is 38 millimeters of mercury. Remember, 35 to 45 is what our normal finding is. This could be problematic for us. So when do we use this? I think that it is still important that we carry something like this or an equivalent in the event that your waveform is not working adequately, so that we have medical legal documentation that yes, we did in fact have color change on a colorimetric device. The problem with these is, and actually I have read the package insert in preparation for doing education previously, that these can be used for up to 24 hours. There's no way. I've transported patients for 20 minutes and they quit changing color when in fact the tube was through the glottis. If it gets rained or any type of moisture on the inside or into that impregnated paper, if the patient vomits, for those of you that have used this, you know exactly what I'm talking about. They're not very effective, but we do need to have some kind of documentation that we have verified tube placement. The other thing that I want to talk about, and I mentioned this earlier, about the hypercarbia, and we can actually create hypercarbia in our patients, especially in the pediatric patient. There are different sized caps. We have an adult cap. We also have a pediatric cap. The connection to the endotracheal tube is the standard size. It doesn't matter if you're putting it on a PD tube or you're putting it on an adult tube. The portion that attaches directly to the endotracheal tube is the same setting or the same size, and that becomes problematic. So what you do not want to do is you do not want to use an adult cap on a pediatric patient, and here's why. Once we've intubated the patient, we take the adult cap, we put it on top of a pediatric tube. There is only so much dead space in the pediatric anatomy. When that individual exhales, the gas, which is CO2, it comes up and it hits this cap. But there's so much potential space in this cap as it relates to a pediatric patient's airway and the dead space, that when we squeeze the bag the second time, we are now pushing this CO2 back down into the patient's lung. It doesn't have the ability to dissipate and off gas from the cap if we're using the wrong size cap. So we can create hypercarbia. There's some documented cases of this happening in the hospital setting, and then through some studies and information that they were looking at to determine if this does in fact happen. And the answer is yes. So only use the right size cap. It wouldn't probably be as problematic using a pediatric cap in the adult patient because we don't run the risk of making them hypercarbic, but certainly do not use the adult in the pediatric patient because you can have some untoward effects from that. All right, so drawbacks and benefits of the colorimetric device. Drawbacks often misused. If you read the package insert, you're supposed to deliver 6 tidal volume breaths before you ever put this on the end of your endotracheal tube. The rationale for that is hypothetically the patient had just consumed a carbonated beverage. You now put the cap on there and you end up getting the CO2 from the carbonated beverage that they were drinking when they had their cardiac arrest event. So there's potential for some misinformation if you're not using the cap correctly. So the device manufacturer, what they want you to do is before you put the cap on your tube is they want you to intubate and then ventilate, or at least ventilate your patient a minimum of 6 times, giving good tidal volume breaths before you apply the cap. The use of the adult device on the pediatric tube that we discussed on the previous slide, that is very, very important as well. Limitation, moisture and vomitus on the paper of the filter. Some medications can interact with that. And we don't really give medications down the endotracheal tube like we used to. There was some mnemonics out there. Lean was one of them, lidocaine, epi, atropine, and Narcan. There are different mnemonics out there that we used to give medications down the endotracheal tube. We just don't do that as much anymore now that we have IO devices that we can use in the adult patient. And then false positives after carbonated beverage is what we just talked about. There are other situations where that is a possibility, but if you just simply go back according to the manufacturer, deliver those tidal volume breaths, hopefully that won't be an issue for you. The benefits, it is inexpensive. I'll give them credit where credit is due. And then again, according to the manufacturer, this can be used for up to 24 hours. I put some elliptices here because we all know if you've ever used this, that's truly not going to be the case. All right, so let's get to the waves. Let's look at some of the waveforms that we're going to be talking about and what those mean. So capnography adds additional benefits not seen with numeric values alone. So if you think back on that far left picture, when we were looking at capnometry, meaning just the numbers, there's not a lot of great information there. Yeah, we know that number was 38 if my memory serves me correctly, but we don't know exactly what that waveform is looking like. Are they having an obstructive pattern? Is their exhalation too long? There's a lot of information that we're not able to get because we don't have the wave to look at. So some of the things that you may be able to look at with your waveform and determine pretty rapidly and with a fair amount of accuracy is obstructive breathing patterns. So we'll look at that. Hyperventilation, hypoventilation, something called a curare cleft, and then tube placement or apnea. From my personal perspective, and as a previous EMS administrator, what I would personally recommend to you all is anytime you have a tube through the glottic opening, you need to have capnography on it. It is a class 1 recommendation from the American Heart, which means that if anything goes sideways and they look at that report and you did not at least attempt to have waveform capnography, you're going to have a lot of questions that need to be answered. So it will tell you where your tube placement is at. It will also tell you if the patient becomes apneic, and that may be for a multitude of variety of reasons. It could be that you have somebody that is supposed to be ventilating the patient, squeezing the bag, and they got sidetracked. They're trying to get suction out or they're trying to get medications out, whatever that situation may be, but they're not effectively ventilating the patient by squeezing the bag. It could be that the tube has become dislodged. So it all goes back to that mnemonic of DOPE, which is dislodged, obstructed pneumothorax, or equipment malfunction. If you can remember DOPE, anytime that you're having an airway issue or compromise, hopefully you'll be able to kind of back up 20 and then punt. The other ones, it is certainly capable of doing that, and we're going to look at a waveform that kind of shows each one of these. But from a legal aspect and keeping yourself out of hot water, the tube placement and apnea is really what you need to be focusing on. Can also be used to guide ventilations for increased intracranial pressure. You have heard this at some point in time, hopefully, with regards to your neuro patients, neurotrauma. We don't want neurotrauma patients to end up creeping up their CO2 levels. We would actually like for their CO2 levels to be on the low end of normal. So if you have a patient that is head injured and you have concerns about them having herniation type syndrome or increase in intracranial pressure, and the way that we're going to know that in the field, really, the primary reason is a change in level of consciousness. That's a good national registry type question that shows up pretty frequently, is how do you know, or what is the earliest indicator of a patient with increased intracranial pressure? And the answer is absolutely a change in mental status. But as that mental status continues to decrease, and we're now worried about them blowing a pupil or having unequal pupillary function, that is when we know that we're now dealing with a patient with increased intracranial pressure, and we need to make sure that that patient is ventilated to an end-tidal CO2 of the low end of normal, somewhere around 35, maybe 30, maybe a call to medical control. Hey, this is what I've got. I'm ventilating at 35. Do you want me to drop their CO2 a little bit lower? And if you're calling a trauma center in that situation and it is presented like that, I can almost assure you they're going to tell you to drop their end-tidal CO2 a little bit lower than 35, probably around 30 or so. And then prevention of increased intrathoracic pressure during ventilation. We are pretty overzealous. And actually, there's some information, I looked it up prior to doing this lecture. There's some information out there where there's some talk from the folks that make the EMS, rules, right, really, protocols, about doing away with adult bag valve devices. And I may have talked don't need that much. And if you go back to when you were last taught CPR, the question is, how do you know if your ventilations are effective? The answer should be chest movement, right? When I see chest rise and fall, I know that I have ventilated that patient enough. Well, we already talked about tidal volume in a patient being around 500. Most of your BVMs are going to be about 800 cc's of tidal volume. So it is way overkill. If we can just simply ventilate the patient to where we see chest wall movement, then we don't worry about the increasing intrathoracic pressure because we're stacking all this breaths into their intrathoracic cavity. So this gets better probably with experience in the amount that you have done this, but certainly you can remember back to when you were brand new, you were an EMT, maybe a brand new paramedic, and you did not have a lot of experience with ventilating patients. You can hopefully go back and appreciate that maybe you didn't do it necessarily by the book. You were breath stacking, you were giving way too much tidal volume just because you're nervous and you're trying to do a really good job, but it actually ends up causing some demise to the patient. So if we have capnography, we can prevent some of these things from happening. So are we doing the right thing? I like to show the other side of things. So there was a summary, basically 2 different studies here, Zhang and others, and then Warner and others. And one was pretty recent back in 2019. The other one was a little bit older. But here's what they said. Although hyperventilation is commonly applied in patients with traumatic brain injury or intracranial hemorrhage, or in those undergoing craniotomy, its effects on patient outcomes have not been proven by quality research. Hyperventilation should be used as a temporary measure when treating elevated ICP or to relax a tense brain. Outcome research is needed to better guide the clinical use of hyperventilation in neurological patients. So what Zhang is saying in 2019 is, yeah, we've been taught that we should probably hyperventilate patients, especially with TBI or intracranial hemorrhage, or the way that we would know that through really Cushing's triad. That's how we're going to know in the field. They have a history that goes along with it. The mechanism of injury goes along with it. And now you're starting to see signs and symptoms of Cushing's triad. Remember, it's not on the slide, but remember what Cushing's triad is hypertension, bradycardia, and erratic respirations. And that's all because of the pressure that's been put on the medulla oblongata which is your cardio and respiratory, acceleratory and inhibitory systems. So all of the head injured patients, if you start putting pressure in that area, they're now going to start to show signs and symptoms of Cushing's or increased intracranial pressure. And that is when we need to start increasing the amount of ventilations that we are doing. And I want to be clear on something here. Hyperventilation is really kind of a bad word in the pre-hospital setting. We should not be hyperventilating the patient. We should be hyperoxygenating the patient to an end-tidal of 35, somewhere in that area, if you think that they have an increased intracranial pressure. Don't go in hyperventilating this patient at 40 breaths per minute. So when we're talking about hyperventilation, it may be that you're only ventilating the patient 16 times a minute. If that's what gets their end-tidal CO2 to 35, then ventilate them at 16 times a minute. There is nothing that says that you have to ventilate them at 30 or 40 times a minute. That actually ends up causing some other untoward effects, and that can be bad for the patient and their outcomes. The second study, the conclusion was end-tidal CO2 has a low correlation with PaCO2, and that's partial pressure of arterial CO2, and therefore should not be used to guide ventilation in intubated trauma patients in the ED. Better strategies for guiding pre-hospital and ED ventilation are needed. And again, this goes back quite a few years, back to 2009. But what Warner and folks were saying is that end-tidal CO2 really doesn't correlate with the blood CO2. Therefore, we should not be using it to guide ventilation. I will tell you that all of the research and evidence in today's world in 2023 goes against Warner back from 2009. So while I don't necessarily want you guys doing or documenting that you hyperventilated the patient, certainly put in your report that you ventilated the patient to the low end of normal for capnography or to an area of around 35. I'm just trying to keep you guys out of hot water and make sure that, more importantly, you're doing the right thing for your patient. All right, so some must knows. Normal end-tidal CO2, 35 to 45. Remember, this is an inverse relationship. As my respiratory rate goes up, my CO2 level goes down. That's hyperventilation. So if you're hyperventilating, you're breathing too quickly, your CO2 is going to be low. If I'm hypoventilating, an example of this would be your patient on an opioid, narcotic overdose type situation. They are respiratorily depressed. Their respiratory rate is down. Their end-tidal CO2 is going to be up. So why end-tidal CO2 when you have pulse oximetry? Well, pulse oximetry looks at oxygen saturation, and it only reflects what oxygenation is. Remember that oxygenation with pulse oximetry, we're looking at one of those 4 binding sites on your hemoglobin. So we say it should be used with capnography. So I'm not saying eliminate pulse oximetry in total. I'm saying keep them on pulse oximetry, but use it with capnography. And really the answer is this, and I'm going to show a quick slide, not go into too much detail on the slide here in just a moment, but it really has to do with a lag when the patient is hypoventilating or apneic. If you have a patient that is pretty well oxygenated and then they quit breathing, it can take a long time for that to show on your pulse oximetry. And I know when I do live review courses, I typically will get a monitor. I will put pulse oximetry on my finger and I will put capnography, the nasal capnography on. I will do breath holding. I will do hyperventilation. And what you can see is the pulse oximetry does not change. And capnography does generally 1 breath behind. So your capnography, it's going to be 1 breath behind. You're going to see it instantaneously. Whereas a patient that is on pulse oximetry, there is going to be quite the delay before you know that the patient has become apneic or is starting to hypoventilate. By the time you see that with pulse oximetry, in reality, it's probably too late. Capnography, on the other hand, it looks at carbon dioxide, and this is reflective of ventilation. Remember that ventilation is a byproduct of metabolism. It should be used with pulse oximetry, so that goes the other direction. But here's really where it comes in to be important. Hypoventilation and apnea is detected immediately. And it really, truly, if you try this, and I challenge you to do that, go out to your bay put yourself on nasal capnography and breath hold. And what you will see is it is literally one breath behind if you do kind of that experiment internally. All right, so this is a slide on pulse oximetry lag. This comes from something known as the oxyhemoglobin dissociation curve. I'm not going to go over the curve, but I do want to tell you kind of how this works. So we are in a unique situation in EMS in the fact that we don't have patients that have, been NPO after midnight and have taken good deep tidal volume breaths, sucking on a non-rebreather with 15 liters a minute. So our patients, they're found down. Maybe they were eating, maybe they were exercising, something along those lines happens, and now all of a sudden we end up encountering them into cardiac arrest. So for our situation, this oxyhemoglobin dissociation curve really doesn't come into effect all that much. Where it does come into effect is in the operating room. So, and I know I don't want you guys going, we're not in the operating room. Why is he talking about this? Just hear me out for a second. In the operating room, when you go in for an elective surgery, they put you on oxygen. The anesthesia folks, they come in, they start talking to you, and they want you to take some good deep breaths. The reason that they do that is they're trying to get rid of all of the nitrogen and replace it with oxygen. Once your cells are 100% oxygenated and all the nitrogen has been removed, it takes a tremendous amount of time for it to let go of that oxygen. And may have told this story here. I know I've told it in other venues. When I was working at UK, we had to do intubations quarterly in the operating room as part of the flight crew. So we go in, they end up telling, they paralyze the patient. I have to get the airway. I look and I cannot find anything that I recognize. There's no recognizable landmarks in this patient's oral airway. I was with a CRNA. I explained to the CRNA, I said, hey, I don't see anything, man. And he was like, all right, let me look. So he ends up looking. He can't find any landmarks that he is recognizing either. We end up getting one of the anesthesiologists, a resident. The resident was unable to find the airway. So we ended up getting one of the attendings. During this time, I quite literally am being 100% honest with you. No one is doing anything for this patient's airway. They're not ventilating him, nothing. He's paralyzed. He is completely asleep. We can't find any landmarks that we recognize, and nobody's doing anything about it. The surgeon that was going to be doing the procedure, he's starting to freak out like, you guys need to be doing something with this. All of the anesthesia folks are basically telling him, you need to worry about the surgery. We'll worry about his airway. They were not concerned about it at all. And the only reason I bring this up is it was truly eye-opening to me how much time you actually have without breathing if you are well saturated. And that is the difference between their situation and our situation. They ended up intubating the guy with an intubating LMA, and then they ended up pushing a tube through the LMA, and that's how they ended up getting this guy intubated. So the research is out there, and if you all want to look this up, you can, Google this term, oxyhemoglobin dissociation curve. It's up to like 10 minutes. So if you have somebody that is well oxygenated and they quit breathing, they don't need anything for upwards to 10 minutes before they will start to have some side effects or bad effects from that. The caveat is they have to be well saturated and have all that nitrogen replaced. And again, in our situation, it just doesn't simply happen that way. So just something to think about. So who can we use it on? Intubated and non-intubated applications. Let me get through here, and then we'll take a quick break before we look at the actual waveforms. So in your non-intubated patients, your patients with bronchospasms, asthma, COPD, anaphylaxis. Remember, with bronchospasm, your asthma and COPD patients, that is a problem getting air out. It is not an inhalation issue. It is actually an exhalation issue, and that is where the problem comes in and what we will be able to see when we look at capnography. Hypoventilation, so drugs, stroke, congestive heart failure, maybe postictal patients after a seizure activity. So if they are hypoventilating, we're going to be able to see that pretty easily, and then we can obviously manage our patient care based on those findings. And then shock and circulatory compromise are another good indication for using capnography in the non-intubated patient. In your intubated patients, verification of end-tidal, or I'm sorry, ET tube placement is paramount. So that's probably the biggest thing, is verification that it is in. And then the second thing is make sure that your endotracheal tube has proper surveillance during transport. We don't want the patient to become extubated, and we did not recognize that. So if they're intubated, make sure that you're using it. Separate part here, control ventilations during CHF and increased intracranial pressure. And then if CPR is underway, then we can tell compression efficacy. We can tell if there are any times that ROSC is maintained or regained, and then as a survival predictor. So I want to talk about these just briefly. Compression efficacy, if that end-tidal CO2 is showing that your numbers are less than 10, we need to make sure that we are either A, switching out with somebody that is not tired, or B, putting them on a mechanical type of device. So with your mechanical devices, either your Zoll Autopulse or your Lucas device, if you're using physio, it doesn't really matter. If you're using one of those types of devices, then you're probably going to get numbers that are much higher than 10. You're probably, in the high teens to early or low 20s, something along those lines. As far as ROSC, back in the day, we used to do pulse checks. So every couple of minutes, you would do a pulse check. I'm just telling you that there's no reason to do that in today's world if you have capnography on. If the patient ends up regaining a pulse, you're going to notice that immediately, because their end-tidal CO2 hypothetically was at 14 under CPR, and all of a sudden it goes to 30. That is a pretty good indicator that there is a change in your patient, in which case now it would be appropriate to determine if the patient has a pulse. If that end-tidal CO2 is 14 and it maybe goes to 15, 16, down to 12, then you know that that patient has not gotten ROSC in that situation. And then survival predictor, why I have this in here, there was some information I thought would come out in the 2020 guidelines that did not. We'll probably be getting a new set of guidelines in 2025. American Heart is generally on a 5-year gap. But what they were looking at is that if EMS got to the patient, intubated them, and we had an initial end-tidal CO2 of less than 10, then we knew it was basically going to be a futile attempt as far as the resuscitation. So there was some information that they were kicking around about not even starting CPR in these situations if their initial end-tidal CO2 was less than 10. Clearly that did not come out, but just understand that that is where the mindset is of some of the individuals that write the protocol. So it may be a situation where we end up seeing that moving forward, but for the time being, obviously follow your protocol, follow the American Heart Association, and resuscitate if and when you feel it is appropriate based on your protocol. All right, it is 10:03. If you guys want, we'll take a 10-minute break here, and we'll pick back up here at 10:13. Okay, it's 10:13. I'm going to go ahead and pick back up here on looking at the waveform. So the capnogram, this reflects the CO2 concentration over time and is divided into 4 different phases. May not be real easy to see, but it's here in red. Phase 1, phase 2, phase 3, and then phase 4. So these are the 4 different phases that we're actually going to be looking at. The first 3, 1, 2, and 3 are looking at exhalation. And then phase 4 is looking at inhalation, getting back down to the respiratory baseline. And this will make more sense to you here in just a few minutes if you're not already aware of what's going on. All right, so phase 1, this is called the respiratory baseline. So if you think about it from an EKG perspective, a lot of this kind of makes sense. So looking from left to right in an EKG, we're looking at time. And as we look from left to right on your capnography waveform, we're also talking about time. So if we take more time to exhale, for instance, if we're looking down here, you can see exhalation is a pretty decent amount of time. If they're exhaling very quickly, then this waveform is going to have a much different look. Maybe it ends over here, or maybe it ends over here, etc. If it is taking them longer to exhale, then obviously that waveform doesn't stop here. It is extended over further because, again, left to right, we're talking about time. The other thing that you can kind of liken it to with an EKG is the bottom line is the isoelectric line if we're talking about EKGs. The bottom line here is the respiratory baseline, meaning basically nothing is taking place at that point. Just like an EKG, there's no electrical activity. The respiratory baseline, there's no inhalation, there's no exhalation. It is just flat. So the respiratory baseline is flat when there is no CO2 present, and it corresponds to the late phase of inspiration and the early part of expiration. So the next part is we start to come over, and I'm actually going to go ahead and move forward to phase 2. So phase 2 is the respiratory upstroke. So I want you guys to think about phase 1. Phase 1, just kind of think in your mind, nothing is actually taking place at that point. Phase 2, if you go back and think about what we talked about with your anatomical dead space, remember you have 500 cc's of tidal volume, 350 are getting down to the business end, and 150 are left in dead space, right? Respiratory or anatomic dead space, which is the part there that is in your trachea or maybe in your bronchus. As you start to exhale, or as your patient starts to exhale, if you just think about the very first breath, the first part of the breath that you are exhaling that is coming out is really coming from your mouth. And then it comes from your trachea, and then it comes from your bronchus. And then eventually, when you're finally almost to the very end of that exhalation, now you're actually getting down to where the gas exchange took place and the gas from all the way down in the alveoli. And that is why this waveform looks the way that it does. As the patient starts to exhale, you can see on this upstroke, this is exhalation. This is all coming from the mouth. And again, some of this is kind of just me fabricating that to show you guys the waveform itself. So the first part, not very concentrated. This is all dead space coming from the mouth. Not very concentrated. This is dead space coming from the trachea. Now we're actually starting to get down into the alveoli. Once we're down into the alveoli, you can see that this starts to actually plateau off, and that is actually going to be phase 3. So phase 3 is a respiratory plateau. It is reflecting the airflow through the uniformly, and that is important, uniformly ventilated alveoli. So this is the business part, right? All of this is gas exchange that has taken place down into the alveoli, and that is why it is so uniformed. It is at a nearly constant CO2 level, and that is alveolar plateau or phase 3. The highest level of the plateau is called the end-tidal CO2 and is recorded as such by the capnometer, which is, again, remember the number. So if we have this uniform plateau, it's plateauing, plateauing, plateauing. The final right side before we end up having phase 4 or inhalation, that is the most concentrated CO2 that they are exhaling. And that is where we end up getting the number of 35 to 45 or whatever that number would be. That end-tidal CO2 is that far right corner. Phase 4 is then the inspiratory phase. So you have finished exhalation. We got our end-tidal CO2 number based on the most concentrated end-tidal CO2. Now I'm taking a breath in. And when you take the breath in, remember, we're not measuring oxygen, we're measuring CO2. So as I am inhaling oxygen, this waveform is going to drop off dramatically, back down to the baseline so that we can start the phase once more. So phase 4 is the inspiratory phase. It's a sudden downstroke and ultimately returns to the baseline during inspiration, where the respiratory pause restarts the cycle, or the respiratory baseline restarts that cycle once again. All right, so normal waveform. I told you before, if you have any variation of a square on your waveform, then we know that the tube is through the glottis in an intubated patient. So square box waveform, it may be difficult for you to see your numbers down here, 0 all the way up to 50. So if we're looking here on this far right peak, that number, if I drew a straight line across, is probably like 41, maybe 42, something like that, which tells us that it's within a normal range. End-tidal CO2, 35 to 45. The management here is simply to monitor the patient. What about if I have a patient that is intubated? I'm doing well. I've got a square box waveform. If I draw a line straight across, my end-tidal CO2 is around 40. And then all of a sudden, I have a loss of that end-tidal CO2 reading. Remember, it is one breath behind. So if you had this, and now all of a sudden you're down to this respiratory baseline and you're not getting any type of waveform, something has happened. The management may be to replacing a tracheal tube. The management may be that your partner that is supposed to be squeezing the bag has been distracted and they're no longer squeezing the bag because they're getting other equipment out, whatever the situation may be. What you need to do is you got to evaluate it, okay? The management here, replace ET tube, obviously, if that is what needs to be done. If it's a matter of your partner needs to focus and squeeze the bag valve device, then that's fine too. But the end result is you have to evaluate it immediately because this patient is no longer being ventilated appropriately. If you intubate the patient and you never get that waveform in order for you to lose it, then you're probably dealing with an esophageal intubation. Remember, the lung, there was somebody told me this a long time ago, the lungs don't puke and the belly doesn't breathe. And that is a fact. In the lungs, if you have an intubation and there's tube vomitus coming through your tube, yeah, it's possible that they've aspirated, but under normal conditions, you should not get any type of vomitus through an endotracheal tube. If you are in fact in the lungs and the patient has not aspirated, there should be that little sidebar. And the belly doesn't breathe. So if you have your tube in the esophagus, and you're expecting to get some sort of a waveform there, you're going to be waiting for a while because it's not going to happen and your patient's going to have a poor outcome. So the absence of a waveform or the absence of end-tidal CO2, basically what we need to do here is back up 20 and punt. The situation may be that you try re-intubating your patient. It may be that you end up going into one of the other devices like an eye gel. If you're not super familiar with them, we're going to talk about them as well today. CPR. So remember, I told you that there was some talk about if you do your initial intubation and your initial end-tidal CO2 is less than 10, that is associated with poor outcomes and the efficacy is very low in doing a resuscitation. It didn't come out, so continue to do what you're doing, but just understand that they are looking at that information. So CPR underway. This is compressions. Your partner's doing okay. You can see here, if we drew a straight line across, it's probably about 15 or so. And honestly, that's probably a pretty decent waveform capnography with a person doing compressions. If you put them on one of the devices to do CPR, the devices don't get tired. So you're probably going to end up finding end-tidal readings a little bit higher, maybe up to 20, somewhere in that area would probably be more realistic. End-tidal CO2, 10 to 15, possibly higher. The management here, you're going to change rescuers if the end-tidal CO2 falls below 10. We know that they are getting tired and you need to change them out. All right, what about an obstructive airway? So let's go back and just talk about this for a second. Remember, phase one, we have just baseline. Nothing's really happening. Phase two is the respiratory upstroke, and this is where this waveform ends up changing. If you recall back to an obstructive pattern, like patients that have asthma, COPD, allergic reactions, those are problems getting air out, not necessarily getting air in. Remember, when we're looking at the waveform, it is all exhalation or getting air out. If it takes longer to get air out, and then you have a sudden inhalation, it's going to end up giving you this appearance of a shark fin waveform. So you will hear that they have shark fin pattern, and that is associated with an obstructive airway. We don't know why. You're going to have to do your history and physical to figure that out, but it can actually be seen before an actual attack. If you have that patient in your district that you're familiar with, you go there, they're the real McCoy, and they tell you that they're having some difficulty breathing, put them on capnography and look at that. You'll actually be able to capture the severity of the obstruction pretty early on. And then after you have managed, and we'll talk about that here in just a second, after you have managed, then maybe you actually start to see some relaxation, and the shark fin appearance start to go away. So it's indicative of something that is causing an obstructive type airway, asthma, COPD, allergic reaction, anaphylaxis, etc. Your management here, bronchodilator. So albuterol, maybe a protropium, depending on the situation. And then epinephrine, if it is a severe enough thing that you need to be administering epinephrine. Remember, that would be a 1-to-1 in this situation, 1 to 1,000 concentration. All right, return of spontaneous circulation. So you're doing CPR hypothetically on these first two waveforms, and then all of a sudden you notice this sudden spike. And so it went from, we'll say, 10 to 15 up here to about 30, maybe 32. You didn't just get better at doing CPR. There's been a change. In this situation, we would check for a pulse and then follow your American Heart Association guidelines for ROSC. And it may be that you end up administering antiarrhythmics. It may be that if they're in the hospital, they put them under an Arctic sun and they do hypothermia protocol. There's a lot of things that go into this situation and decision making. But the bottom line is follow AHA guidelines in your specific protocols and you should be good. All right, a rising baseline. So what they're looking at here is, here's your, I wanted to say isoelectric line, your respiratory baseline, but you can see that baseline is starting to go up. It is no longer coming all the way back down. This is that situation where you're making the patient hypercarbic, or the patient is making themselves hypercarbic. The patient is rebreathing their CO2. This can be bad long term. You don't want to do this. This would be the situation where with like an easy cap, you're noticing that the easy cap, or if you're ventilating with the inappropriate sized easy cap, this is what the result would basically look like. All right, management here, you're going to check equipment for adequate oxygen flow. Make sure that you're not out of oxygen. Otherwise, they are going to be rebreathing their CO2. If the patient is intubated, you need to allow them more time to exhale. So again, back to those of you that have transport ventilators, if you have the ability to manipulate IE ratios, this would be a situation where you would want them to have more time to exhale. And what your IE ratio is inhalation, exhalation. And there's some strategies there on how you best do that and whether or not they have ARDS and all kinds of situations that go into that decision making. But if you have the ability to do it, then you would want to extend your exhalation if you see a rising baseline. All right, hypoventilation. So remember, this looks maybe a little counterintuitive. Remember, hypoventilation, their oxygen is low, so their CO2 is going to be high. And that's exactly what's going on here. Their CO2 should be 45, but you can see it's up above 50. So it's an end-tidal CO2 of greater than 45 by definition. Your management here is going to be to assist ventilations or intubate your patient as necessary. On the other side, hyperventilation. So my oxygen level is high, my CO2 level is going to be low. So it should be up here at 35, and you can see that it's lower than that. We're down here to about 15. So we are hyperventilating. If the patient is conscious, this gives good biofeedback. If ventilating your patient, then you need to slow your ventilations. And this is a very difficult thing to do. But if you're getting this hyperventilation or shortened waveform at 15 on a patient that you are ventilating, and let's say you're ventilating them at 18 times a minute, you may have to drop down and ventilate them at 8. So the evidence is there. There are people that will back you. Your medical director should back you. We should not be counting the ventilations. We should be looking at capnography and guiding our ventilations based on the number and the waveform that we are seeing, and it should be somewhere around 35 to 45. Consider underlying causes for hyperventilation with low end-tidal CO2 readings. Hyperventilation, panic attack, those are the first ones that come to mind. DKA, or diabetic ketoacidosis, when they go into Kussmaul respirations, they're going to start hyperventilating in that situation. So less than 25 is probably what you're going to see here. And then in your septic patients as well, less than 25 millimeters of mercury, it is a pressure measurement. All right, the patient breathing around the endotracheal tube. So look, here's your respiratory baseline. Here is exhalation. Here's the plateau. The far right corner is my number. We'll call it 40 here. But now look at inhalation. when the patient inhales, it doesn't go straight back down to the baseline. It's actually taking time for that patient to inhale. And that is because one of a couple things: either if they're intubated, the tube is too small, so when you're giving your breath, it's taking longer for that breath to get in. Is probably what the situation is in an intubated patient. So if it's pediatrics, it's too small. Basically, the management is going to be to check the cuff, make sure that you don't have a cuff rupture, first of all, because now you're getting some gas exchange or gas escape, I should say, that's not going into the trachea. It's basically kind of leaking around. And if the cuff is okay, then you need to be looking at increasing the size of your endotracheal tube. One thing that kind of comes up in continuing education sometimes is, all right, if I had this, would I pull it? My personal opinion is no. If you have this situation, you have a patient that has been intubated in the field by you, and you see a waveform that looks like this, I would leave that thing in. I understand that we may end up having to re-intubate them at some point in time, but the bottom line is, in the field, in the pre-hospital world, try not to pull a tube that is in and being mostly effective, right? Yeah, maybe we should increase the tube size diameter a little bit, but I think it is much safer for you and your patient for them to be extubated and then re-intubated in the hospital, where they have a bunch of people, a bunch of resources, and the equipment to be able to do it. It's just my personal opinion. Obviously, you're going to be the one there faced with the adversity. You need to make your decision, but just some food for thought. All right, the curare clef. So the curare clef is when neuromuscular blockades start to wear off, and those are from your paralytic medication. So maybe they were paralyzed with vecuronium or rocuronium or the succinylcholine. So if they have any type of neuromuscular blocking agent that is on board and it starts to wear off, this is basically where the patient will start to kind of buck the tube. And that is called a curare cleft. And what ends up happening there is the patient's actually starting to take small breaths on their own. So here's the exhalation, and then the patient takes a breath, and it kind of resets that cycle. That's why it looks the way that it does. If you are in the business of paralyzation and giving these medications to your patient, then the management here would be the re-administration of a neuromuscular blockade. So if they're already intubated, then it would be appropriate to use a long-acting like vecuronium. If they're initial and they're not completely down, then you're probably using a shorter acting, in which case you're not going to see the curare cleft to begin with. All right, so what does all this mean to me? End-tidal CO2 is a great tool to help monitor the patient's breath-to-breath status, and I think that's very, very important. It's a lot better than the use of pulse oximetry, just because pulse oximetry does have the potential for that long leg. End-tidal CO2 can help provide or recognize airway obstructions even before the patient has signs of an attack. It will help or can help you control end-tidal CO2 of head injuries. More information is needed, and that goes back to the studies that have been done as we looked at 2009 and 2019. I think the evidence is more favorable now that we maintain that level around 35 or so, and now they're actually adding in some of the hypertonic saline, so like 3% saline, etc. And then it can help you identify ROSC and cardiac arrest patients. So hopefully that was a review for those that have used capnography. It is part of the national core content. So again, some of these things I really can't get around. We have to talk on capnography. If you've not had it before, hopefully you got some good information out of it and it was helpful moving forward.